first one here, we are going to be talking about accountability interventions, focusing on community-based accountability interventions. And later in the evening, we will be talking about performance-based performance incentives and empirical contract theory, basically. Okay, so with that, I believe you can see my screen. We can go ahead and get started. Come on. All right. You can see the screen share, right? Yeah, good. All right. So what I'm going to do, and I'll be a little transparent with you. There's going to be some shameless self-promotion where I will give you all of the context of the literature and tell you what's been done. But I will also take the opportunity then to tell you what the limits of the literature are. And for fairly obvious reasons, I'm going to try and present research which I believe sort of extends that literature. But at the end of it, when we come back to sort of weighing the empirical evidence from the paper I will be talking in more detail about, with the research that's been done so far, we should think more broadly about what does this mean for accountability interventions in general, and have we learned anything that's broadly generalizable, or is it just this one little specific context? Great. So going back at least 15 years, we have been documenting some serious problems in public sector delivery. Most of us who've grown up in or live in developing countries know this problem very well. Whether you go to the doctor, whether you go to the healthcare clinic, or you go to get public education, there are huge problems in public sector delivery. Some of these public sector delivery problems could be managerial issues because of the fact that there are improper incentives or the sort of monitoring mechanisms are not in place. There's problems with tenure, there's problems with lack of salaries, all of these problems. A more recent sort of stream in the literature has also tried to examine this problem of public sector delivery in the context of saying maybe we are not doing enough to attract the right kind of people into public service. That is, if we had brought in, if we had a better screening mechanism to find people who are more pro-socially motivated, people who really believe in the cause of public sector delivery, maybe we would have a better set of outcomes. Now that set of questions we will not get into in this particular session. Save that for the incentives conversation later in the evening. But you can see the link between the two. At the end of the day, there are individuals who were supposed to do something, whether it was delivering care as a frontline health worker or as a teacher in education. And we know that in public sector settings in particular, there seems to be a lapse that we worry about. That is, people are not working. So now, given that broad context, there have been a bunch of different efforts which have looked at the idea that maybe we should be, rather than saying, let's do administrative reform, let's do major financial incentives or other interventions of that sort, can we think about encouraging the end user, the communities, to participate in monitoring the delivery of what they should be receiving, so that there are two goals we can accomplish with that. One is this idea, the central tenet of participatory governance. That is, the individuals who are supposed to participate in the governance of the system that they are entitled to. And by being part of that, they're not just pointing fingers at somebody who was supposed to do something, they're actually actively engaged in making it better. And that process of participating actively in governance can help improve the development goal, achieve these development goals. Right? So that was the basic tenet. Now it turns out there is a broad literature in development. Some of it is in the context of communications, in the context of information interventions, using community-based interventions in the context of education, food supply, infrastructure. And what we find broadly there is that the evidence is quite mixed. There are some efforts that have led to fairly large improvements. So, you probably, when you think about accountability efforts, Ben Olken's work in Indonesia on the roads was sort of a big set of studies he had done. Everything from digging up the roads and giving information about threat of monitoring, trying to get the community involved in that process. You can think about initiatives where, and I'm thinking more broadly about the corruption, information transparency literature here. There's a lot of work where you can think about providing information on the types of contracts that are being made. And you will find that the amount of corruption goes down. That's because there is And once information comes on the table, that transparency leads to a better possibility of the end users being able to question them, right? So in all of this, if you think and pause for a second in what I just told you, there's two components to accountability. One is that of whether information is available to end users or not. Is that information, and we'll characterize what that information needs to be. And the second is conditional on having that information, is it a coordination failure? That is, do we need to think about mechanisms to facilitate participation in this democratic process that we're talking about? Right? It's entirely possible that the failure is one and not the other. It's possible that both of them are equally important, but we don't know that. It turns out that broadly, when we think about community mobilization, there's a lot of different types of efforts that have happened. So India has got tons of, especially in the grey literature, there's a ton of activity that's happened. So, when you think about all the participatory governance type of activities that the NGOs have done, the Jan Sunwais and stuff that they've been trying to organize, these are all getting at that same issue. But for us as empiricists, when we look at this, we need to break it down and try to see, can we say something more concrete about the information failures versus is it about the communication failures, right? So this is where I want to draw your attention to. So I'll spend a bit of time on this particular slide. And the reason is because this is sort of the main set of papers that have come out focusing on the relationship between accountability, interventions, and health. I believe a number of these, if not all of these, were on the reading list that was circulated. So let me jump in and start with first pointing out that we are focusing exclusively on health in this context. Okay. Now, when we come to the second discussion about empirical contract theory, I'll tell you all the reasons in which working in health is especially difficult for contracts. Okay, we'll leave that aside for now, and we'll focus on the idea that we are trying to think about accountability interventions where you give information or participation to improve certain health outcomes. Well, the most widely known paper in this, most of you have probably seen this, is the 2010 Bjorkman-Svensson paper, The Power to the People. Since most of you probably know it, I'll summarize it very, very quickly. What Bjorkman-Svensson did, and this was very novel at that time, is they were trying to run a small randomized controlled experiment. It was in 25 villages that they introduced the intervention. Now, the intervention is worth spending a second on, actually more than a second, a few minutes on, mainly because a number of the other papers that I will talk to you about either try to replicate it or try to build upon it or build some variants of it, right? So it's actually a very important landmark in this entire literature. What they did was they said, all right, there could be an information problem, but the information problem could be of a following sort. That is, let's say Kumar and I are both residents of the same village, and when I go to the doctor's office, I don't get services. I think it's because the doctor does not like people with bald heads, or there's some discrimination against bald people going on, and so I feel bad about it. I come back home, I sulk, and I get over it. I assume that maybe Kumar gets better treatment because he doesn't have a bald head like me. So then only when we collect information about all of our experiences and collate it do I start realizing that, wait a minute, it's not me. This is a community level problem. Knowing that the information, knowing that the problems that I face are not just my own, but there is a collective nature of these problems, helps us redefine what the problem is in the first place, right? If it's not just my problem, if it's all of our problems, maybe we can do something about it, right? So that was the first insight that they were trying to chase. What they did in order to accomplish that was they first did a household survey. That household survey enabled them to summarize what the health problems in the village were in terms of the health outcomes that the children had, and some level of satisfaction with the providers, some aggregate information about whether healthcare workers were showing up or not, what the absenteeism looked like, and so on and so forth. Once that was available, they introduced a meeting. And what the meeting was done was, what was interesting here is that they didn't have very many meetings. They had one major meeting at the beginning of the year where they brought together the community members who had received information about what percentage of children in their village had problems, what were the aggregate problems that everyone in the village would, with the care that they were receiving, and so on and so forth. And then they were able to then tell the doctors, look, doc, we are not happy about these outcomes. We are not happy about the fact that you don't show up to work. We'd like you to treat us better. So facilitated meeting, right? At the end of this facilitated meeting, a year later, what they found, and this was the surprising part, is beyond this, there was no clinical intervention. It was not a continuous effort where the team was in the village every week or every month or something. They collected this data, given the information back to the households, and organized this facilitated meeting. That had a massive effect, a 30% reduction in under 5 mortality, right? That's a giant effect size if you think about what it was. And this is only in 25 villages, right? But it had a very large effect on the global community when you think about accountability interventions. Institutions like the World Bank and everyone, all the governments loved it. At least a cynic's view on this would be that there are many reasons why governments would like it, right? Because here is a development intervention where you don't have to do anything. So if I'm the government trying to look out for a cop-out strategy, this is beautiful. All I have to do is give some information to households, organize a meeting, and then they sort their own problems out. I don't have to do anything, right? Until now, people were coming and yelling at me as the government because I wasn't doing stuff for them and organizing programs or doing policy refunds. This was beautiful. I mean, that's the cynic's view. The more sort of, I would say, a little more compassionate view of all of this would be that this has a potential to actually create the kind of accountability that we want, and maybe service delivery actually improves. So the World Bank, along with a lot of different countries and governments around the world, had started, and I'm picking the World Bank only because they were our partners in this, but a lot of government, non-government institutions globally have been doing this. They've been encouraging these kinds of efforts. Going back to this question about is it information versus facilitation, so Martina Björkman and Jacob Svensson were thinking very hard about this. And what they did is in a follow-up paper with Damien DeVog. So going back to the Björkman-Svensson 2017 paper, what they tried to do together is that they were trying to tease out the effect of information versus facilitation. And so in order to do that, what they did was they had one arm where they provided both information and facilitation, exactly like the 2010 Power to the People paper. And then a second arm where they introduced only facilitation. And what they find is that doing only facilitation has no effect. Okay. Now the problem with that, in my view, I mean, I can see that from a methods point of view, it's perfectly fine, and statistically and mathematically, it makes perfect sense as well. If you believe that these are additive effects, you should be able to separate them out in this particular research design. The problem, however, is not about the methodology per se, than about the practicalities of how you organize community facilitation or community meetings. Here is an example. If Kumar had sent out a message to all of you saying, look, at 3:30 p.m. there's going to be some meeting online, you guys should all come. And he doesn't tell you it's part of ISI's or the IGC ISI Summer Institute. It doesn't tell you what the topic is. It doesn't tell you who is speaking. My guess is most of you would not have shown up, right? And even if you did, it wouldn't have necessarily have been the same group who came here because they were interested in this particular topic, okay? And that's the key part here, is that if we want to think about facilitations or facilitating meetings for governance, participatory governance, we will have to give households a certain amount of information about what the context is, about what the reason why we are coming to do there, what we are trying to accomplish. And then at that point, in some sense, we are asking about more or less information. It turns out, even if you take that critique very seriously, it only adds further strength to their argument that even if it's just more or less information, their conclusion was that information is very powerful, right? Now, the only downside, so I think this is fine. There's nothing fundamentally wrong with all of this. The downside with this is, if you want to talk to a policymaker and say, look, you have option A or option B or option A plus B, then you have to think, is the policymaker going to be able to implement option A or B as a standalone mechanism? And it turns out trying to get policymakers to do only facilitation mechanisms is very hard to see. You can't really explain to a policymaker how you would do facilitating of meetings for governance without having any information there, right? You can do like just chai party meetings, everybody comes together, has a cup of chai and vadas and goes back, but that won't accomplish. So it almost feels like you're setting up a straw man there, right? The alternative, which is what they hadn't done, is the one where you can do only information interventions. Now, economists love this idea, right? The idea that there are information failures in the market. Once you take care of the information failures, everything goes back to normal. The world is a happy place. We don't have to do anything. Great. So it turns out that is exactly what we are going to try to accomplish in the paper. I'll tell you subsequently. But you can see where the setup is already. Is the 2010 paper gave this big empirical finding, which was this big splash. 2017, they tried to separate it out, but they did it slightly differently in a way that it felt like you're setting up a straw man. And then the other three papers are really important to consider. These papers did not try to get at the mechanisms, but instead they were thinking about the scale issue, which is super important in development. Right? If I came to you and told you, which is exactly what I'm telling you now, is here was a study done in 2010 in 25 villages in Uganda, and it accomplished something miraculous. So let's go ahead and implement it all over the state of UP, which has got 200 million people. That's just ridiculous, right? Because you don't know whether you can implement it. You don't know whether the interventions you develop for the 25 villages in UP are exactly what you need to implement in Uganda is what you need to implement in UP. And it's not entirely clear how you scale up something like this, right? So the first paper that I'm going to tell you about here, the Raffler, Posner, and Parkinson. This is Pierre Raffler, Dan Posner, and Doug Parkinson's paper. This is a really impressive paper. What they did was they said, we'll take the QJE 2010 paper, the Power to the People paper, at face value. Let's say it works, and it works exactly the way the paper claims it works. Let's scale it up. So they got this giant grant from DFID, and they implemented this program on a large scale in most of Uganda. Okay. The first problem that the paper runs into, and this is not anyone's fault, it's just the reality of trying to scale up any good intervention that's done on a small scale, is how do you find the people who can implement this program? So what they did was they said, rather than trying to do what Bjorkman-Svensson did, which was a very sort of curated 25, it was a randomized intervention, but it was a selected set of areas working with agents, or in this case, graduate students, as well as field level operatives that they had very carefully picked and trained. These guys said, we are operating nationally. We have no way of doing this. So we are just going to find any NGO who's willing to do this, any contractor who's willing to do it, and then contracted with lots of different small entities who were able to implement this program nationally. And what they find, not surprisingly, is although the design was exactly the same, the design was supposed to be very simple, right? Do a household survey, find these summary statistics, report the statistics to the households in the meeting, and organize a facilitated meeting. This is not rocket science. Should have been able to do it, but it turns out it did not work. What you find there is, instead of a massive under 5 mortality reduction, what you found in the first round in Uganda, you find very modest impacts on treatment quality and patient challenges and patient satisfaction, right? So this was sort of a big deal, that when you're trying to take up something that looks very, very good on a small little scale and you scale it up, maybe things just don't work, because there are many small little details about the implementation of a development intervention that you cannot scale up, right? So then the other T4D study that Arcadis and others have, it's a slightly newer study actually. They tried to do the exact opposite. They said, well, on one hand, what Raffler and others did was they tried to scale up a small, very precise intervention, which was previously developed and implemented, and scale it up exactly as it is. But when you scale up something exactly as it is, maybe you're not meeting the needs of the other communities where you go to. And there might be some contextual differences because of which what works in village A might not be appropriate for village B. Maybe that's not how you should be doing it. So these guys did something very different. They said, we are going to turn this thing on its head. And we will take the spirit of accountability, but let the community do what is necessary for them. And so in this case, what they did was they worked in about 100 communities in Indonesia and another 100 in Tanzania. So the scale was there, but then they basically let the community do whatever they wanted. So it had a facilitation mechanism, but the community was left with the responsibility of identifying its own priorities, identifying the problems, the solutions to the problem, and a way to implement that. Now, if you think about the sort of human capital required to organize yourself, and maybe they help them with the organization part. But then the second part, where you look at a problem, a situation, identify the problem, identify a solution to the problem, craft a sort of a process through which you're going to implement that solution, and then get it implemented, is really, really hard. Right? If these villages and communities were able to do this much, chances are they would not be that underdeveloped in the first place. Right? So there is this problem, is that when you turn the model on its head, plausibly the inability of community level organizations or communities in general to independently do all of this is a tall order. Right? So if you think about the spectrum, 2010 paper did a fantastic job. It was on a small scale. You blow up the scale, you have a problem. You change the design, you have a problem. So now what? It turns out that there are some other projects that have been looking at some aspects of this, where you improve participation in meetings, you improve participations in community, and you have some effects. So Ghazala Mansouri and Javier Gine's paper that I just cited back there, sorry, I have multiple screens in there, so I have to sometimes leave behind and see what's happening there. It basically shows there's some improvements on the improved health delivery stuff. Okay, so that is basically the overall where that literature stands. But let me just to remind you. So here's this paper that we have been working in Uttar Pradesh for the last 5-6 years now. Actually, the paper, we finished data collection in about 2018, so it's 6 years since then. And what we tried to do was try to answer these exact same questions. And so this was funded by the World Bank and government of Uttar Pradesh and the Gates Foundation. And we had a bunch of folks who helped us along the way. This is joint work, I must mention, with Vikram Rajan at the World Bank, Kendall Swanson, who's now a PhD student at Duke, and Harsha Tirumurthy, who's now at UPenn. Okay, so just to remind ourselves, what our objective here was, this was the time when the government of UP, as part of a very large World Bank funded project, wanted to introduce something called social accountability. Now, social accountability is one of several different types of programs that are included in this broad umbrella of community monitoring mechanisms or community-based accountability interventions. And what social accountability tries to do is essentially, one, exactly the same as we said. It needs to have information. So it's trying to solve some information failure. And there is what they call a redressal mechanism. That is, once the communities know that, look, I face this particular problem, I need to be able to do something about it. So you also have to provide a platform where they can possibly solve this problem. You can't do what was done in Indonesia and Tanzania, where you just let them figure it out, right? So social accountability requires that we give them information about the problem. We give them some redressal mechanism, and as part of that redressal mechanism, we also have to inform our constituents, in this case citizens, about their rights and responsibilities. So one of the things we know from the political economy literature is that oftentimes, we might say that there are these government mechanisms and programs that are supposed to help, but people on the ground don't know that, right? So we'll have to do three things. One is give information about the health problems. Two is give information about rights and responsibilities. And then third is this facilitation mechanism. So now you can see it's starting to take a little more structure there. However, the UP government, and this is to give them full credit, when we started conversations with them, they said, if you have an idea that's going to be a small little cute study, we are not interested. We don't want another cute study that you will do just for research. What we want you to do, if you're going to do this, do it with us in a way that is actually not just scalable, but do it at scale. Let's develop something and do it in a way that not just shows that it can be scaled, but let's do it at scale. And then you tell me what the effect of this program is. Okay, so that was the two constraints. One was whatever we developed could not be developed in a lab or in our university offices. It had to be developed as a policy intervention that's developed and implemented by the state government of UP. Second is it had to be at scale. And the third condition was they said you cannot create any new institutions for the program. This is going to be a big program, we get it. But if you're going to create new or parallel institutions that work exceptionally well under your monitoring and supervision and management, that's not scalable. You have to work within the confines of the existing government mechanism and see if you can develop something. If that means it takes time, that's fine. That's just the reality of what it is. Okay, so it was a very challenging prospect, but I think they asked us to do the right thing in this case. So what I'm going to show you is actually the data that comes from a randomized field experiments from across 120 villages, or in this case, they're GPs. For the global audience, we call them villages, but most of you know that a GP includes multiple villages, right? Now you might ask, why only 120 villages when I gave you this big drama about how scalable it is and stuff? Well, it turns out I'm only showing you data from 120 villages because that's where we collected data from, okay, and where we targeted some of the interventions at. The policy that the government developed and implemented was developed and implemented for 12 districts in UP. But we had managed to convince them to implement the program in half the blocks in these districts. So these are very large areas, and roughly about 20 to 23 million people in these areas. I'll show you the map and I'll give you more details. But because this was such a large area, in UP everything is large, because this was such a large area, what we did was we got the state to implement its existing program as it's being rolled out in the study areas we had selected, right? So it's almost like you're going to the village, someone's going to the river to get a big bucket of water, and you give them a test tube saying, "Thoda isme bhi bhar do," because I want to test it, right? It's literally like that. There's a big bucket of water someone's filling up, and they give you a little bit of extra water in the test tube. That's what you're going to be studying. So what I'm going to show you is the test tube equivalent, but it's being collected at the same time as the big bucket of water is being collected as well. Great. So just to give you a sense of, because I told you that our results are not anywhere as close as impressive to the 2010 paper, let me just remove the drama and just show you what it is. Okay. The outcomes in blue that you see here are the information plus facilitation villages. Red is the information only villages. And the ones you see up top here are basically the health outcomes. So these are nutritional outcomes. There's some improvement. Not all of them are statistically significant, especially the two that we really care about. They're not really, they managed to cross over our zero line, which is terrible for us, but it is the reality. The big effect that we see is on full immunization rates, and I will talk more about this. This is a very large effect on rates of full immunization. We do see some effects on whether health-seeking behavior in the facilitation villages only. That is children getting treated for diarrhea within the same day. There are fairly large effects on institutional delivery rates, and this is also important as we think about the design and why this is relevant and stuff. These things that look negative here, this is exactly what you would expect. This is about satisfaction with providers. So you go into a village and you tell the people that, look, your A&M is supposed to be giving you treatment for all of this stuff. Your ASHA worker is supposed to do all these 50 things for you, and your Anganwadi worker is supposed to give all these programs and deliver things to you, but in reality it doesn't happen. Chances are the effect is going to be negative, not positive, right? So that's very consistent. Again, sadly, our sample sizes are not enough to be able to pick up any of these differential trends, but across the board it looks like the blue areas, which is information plus facilitation, the decline is at least lesser than the red one. But again, as you can see, none of this is statistically significant, so take it with a big bucket of salt, if you will. What we do find is that there are some improvement in birth outcomes. I'll come back to this later on. Okay, so I told you about the areas where the study is coming up. So all the yellow shaded districts are the ones where the state developed and implemented the program. Okay, So this is part of the UPHSSP program, which was a several $100 million, one of those big World Bank funded projects and stuff. So while this was happening, we managed to, as they were designing this, we were helping them with the design of the program. We said, while you're going to implement this in the 10 districts, we also want you to extend the implementation into these 2 districts. But we want you to go in there and implement it only in our study areas. You do exactly whatever you're doing. Don't even ask us about whether you should do, what you should do, when you should do it. Whatever you do in the other areas, do in these areas as well. Just that we will tell you where to go and where not to go. That's it. We'll draw the boundaries for you, and then you can do whatever you want, right? So that's how we accomplish one part of what the government is scale and replication problem is. If it's going to fail everywhere, it was going to fail here too. If it was going to work elsewhere, it will work here too. That's all I have to say about that. Okay. Then what we were doing is this is where we want to think a little bit about the context and the relevance of what this accountability intervention does. So as most of you know, the healthcare in frontline in India, frontline health workers are 3 kinds: the ASHA, Anganwadi, and the A&M workers. The UPHSSP project, which stands for Uttar Pradesh Health System Strengthening Project, it aimed to improve service delivery and outcomes. And so they were trying to improve the outcomes for these 3 frontline healthcare workers. And it turns out there were 2 existing government institutions, and I use the institutions broadly in the econ policy sense. One is the Village Health Nutrition Sanitation Committee, VHSNC. This was actually mandated by the National Health Mission guidelines and has been on the books for almost a decade now, over a decade even. The VHSNC is a statutory body that exists at every village. The Gram Panchayat, it constitutes it, with the Pradhan and the Secretary being members of the committee. And they then invite 5 or 6 other people, including some ward members, some of the frontline healthcare workers that we talked about, and people from the village to be on the committee. Their job is to identify health priorities for the village. So whatever is a problem that the village faces, and it could be in some village they need some chlorine to fill ditches. In other villages they might need to buy mosquito nets, and in a third village they might need to buy some equipment, some sphygmomanometers or whatnot for the, excuse me, just a second. Sorry about that. So if they need to buy any equipment for the primary health center or something, they could do any of that with that. So it's not much money. It's only about 10,000 rupees a year. But the VHSNC also has the authority to request senior officers, like the block level officers or the PHCs, to get more funding and support if needed. Right? So that's exactly what it does, is as a statutory body. Now, what they also are supposed to do is they're supposed to coordinate something called a Village Health Nutrition Day. Every month, they organize a day where these services that are provided by the 3 A's, Anganwadi, ASHA, and A&M, are coordinated and delivered to everyone. And the focus is on primary care, immunization, ANC, and nutritional supplementation. So now this gives us a very nice window into the possibility of a governance intervention that improves the delivery of services that are very targeted, these 3 services. It also gives us the outcomes I showed you about earlier. Nutrition is clearly super important. It could be improved either through nutritional supplementation or through providing better primary care, because then kids are not getting sick all the time and hopefully getting better treatment when they get sick. Immunization obviously is a super important one here. Antenatal care, because that's what the A&M and the ASHA are supposed to do, and hopefully help women get better antenatal care and deliver healthier children, maybe deliver their babies in hospitals, and so on and so forth. Okay? So that sort of is the sort of broad context in which we are going to look at. The other part of the context, this is again getting to this issue of scale and sustainability. Remember, the government had told us very clearly, no new institutions. We can't set up a project office with like 50 people working there and they can do all of this. So right off the bat, what they said is, if you want to do this, it cannot be done through the World Bank project office. It cannot be done by a UPHSSP. So to avoid this problem of like the lack of sustainability of these types of efforts, UPHSSP instead gave a very large contract to the State Institute of Rural Development. So those of you who are from UP might know that UP has a very large and very successful SIRD. It is the state's apex training institution. They conduct trainings for all kinds of things, everything from law and governance to frontline healthcare workers to teacher training programs and everything in between. Okay, that's what they do. They are a training institution. So they appointed the SIRD to implement this program and said, we will work with you to develop the implementation. So they developed all the training materials and the information brochures and all of the policy guidelines and everything as if it were just another standard government program that they're running. They also went through the process of recruiting 316 GPs. So 300 was for the yellow districts I showed you and 16 that we wanted in our areas. Sorry about that. So the GPCs are the Gram Panchayat coordinators. These are the guys that the government was going to hire under this program to do the facilitation we talked about. Right? So right off the bat here you can see, if I or my co-investigators had done the recruitment through our university affiliations or our research partners, clearly we would have got very different people. Instead, here is the government doing a recruitment of 316 people in UP, rural parts of UP, through the standard government contracting processes. And everything that you can think that can go wrong with government HR contracting does go wrong. And I can tell you will go wrong and did go wrong here, right? So, your guess is as bad as mine. Everything from complaints about bribery, people having to give kickbacks, people being lied to about the jobs, everything happened. And we would hear about it, but we said, no, we won't intervene because this is the real world. If this program needs to be evaluated on its merits, it has to go through this painful process. Let it go through. This is why a one-year program took 6 years to develop and implement, right? So we started in 2011, and you will see that it took a long time before 2016 is when it actually hit the ground. And that's because of this kind of recruitment type of problems. Once recruited, the GPC is sort of the linchpin of the government intervention. This person is supposed to activate and facilitate these institutions, the VHSNC institution. You might ask what it is. What it is, let's say Kumar and I are members of this committee. Kumar is the Pradhan, and we put down names of 3 of our friends, and we created this committee. Nobody knows about it. We never meet. So to activate it, the GPC would come to the village, meet with us, tell us this is a government-run program, this is a new policy that we're going to activate it. Please show me your register to show to find out who the members are. Once the GPC looks at who the members are, then they go knocking on each one of your doors and say, hey, look, I'm going to pick one of you just because I see some names on the screen. So Nandini, let's say, is one of the members. I knock on Nandini's door and say, hey, Nandini, you're a member of this committee, and here are your rights and responsibilities. These are the tasks that being on the committee means for you. And by the way, next Tuesday at so-and-so time, we are planning to have our first meeting. So now you have managed to activate this committee, right? You've talked to all the members. You've created what in the information economics literature we call common knowledge. Everybody knows what everybody else knows. That is, these are the rights and responsibilities, and a meeting is going to happen. Once you do that, then you also invite everybody to the meeting, which is simple. It's just about matter of giving information to households. Now, just to give you a sense of scale here, over the period of this project, SIRD had managed to train 10,000 VHSNC members all across the implementation areas. So they started in May 2016, and over time they would hold these workshops in all of these areas to bring people in, train people about what these committees are supposed to do and how they're supposed to organize themselves. This gives you a sense of what the meeting pace was looking like. In early 2016, when we were still piloting these interventions, that's these little blips you see here is the pilots we were trying to conduct, see if it works or not. And then because this is UP, even a pilot there is like 50 villages. So they're actually this is a significant blip. But then after that, once the program hit its stride, on average, UP was holding about 2,000 meetings a month, which for those of us who are sort of used to hearing about all these terrible things about governance and implementation in UP, this was quite surprising, right? That a government institution is able to implement this program on this scale. Now, this is really testament to what SIRD was able to do. And in that sense, it is somewhat of a unique institution within the government. We can talk more about why that happened and the unique political climate and the leadership that made it possible for SIRD to do that. These are not trivial details, actually. Okay. So going back to the question that came up, what we were trying to do here is in these two districts where we told the government just replicate what you're doing elsewhere, we wanted to estimate the impact of the government-run program, what they were calling the Social Accountability Initiative, the SA program, when it's implemented as well as possible within their constraints, which means if they're not able to recruit people because of corruption and payback issues or whatnot, it won't happen. But conditional on that person being recruited can we make sure they're able to do their job. So essentially ensuring higher fidelity as much as possible without changing the design. So we added two elements. The first was information dissemination, which will become part of the intervention. Now this is very easy because all we did was recruited a local firm and gave them a contract to say you have to go out and disseminate this information. There was nothing sort of particularly unique about it. It was about going house to house, giving them information and being able to then collect data while they are at it. So this is like any standard large scale contract that the government would give. And the second part was where we assisted and monitored the GPCs in our areas. You can see now why it was necessary for us to work on a smaller scale, because trying to do this across 10 to 12 districts in UP is a gigantic effort. We just don't have those kinds of resources. So we hired a separate firm through the World Bank, and their job was just to call these guys and say, dude, you were supposed to organize a meeting next Tuesday, have you done it? Good. On Sunday, call and say, you were supposed to leave for this village, why are you still here? People will be waiting for you on Tuesday, you need to start moving, get going now. That's it. Okay, so they were not actually implementing the village, they were just in the villages, they were facilitating the facilitator, so to speak. So this was the question that earlier somebody asked about the information versus facilitation. So just to recap, we have three arms. In one arm, only information is given to villages. That is information just like in Power to the People, where you have information collected from baseline surveys about the state of the child health in your village relative to other villages in the district, as well as to a statewide average. And in arm two, in addition to the information, we have the government-run facilitation that I described to you, right? So the other thing that we did was we introduced, in this case, something called a matched trio randomization. So some of you probably are familiar with the Gary King paper, where Gary King and Kosuke and others describe the matched pair randomization. So it's called what they've called a politically robust evaluation. If you're not familiar with this, this is a really cool paper that describes the value of doing a matched pair randomization for policy evaluations. And they did this in the context of introducing health insurance reforms in Mexico. The one sentence summary is they wanted to do a randomized experiment on a very large scale. Their worry was once they announce the policy, some areas will say, I don't want to do this. Who are you to tell me we should do it? Other areas might say, hey, wait a minute, this looks really cool. I want to do it even though I'm in the control. So you will have essentially contamination, and that might be very severe in some cases. You wouldn't know what to do with it. What matched trios does, what matched pairs does, and trio is just an extension of that, is you basically have created matched pairs before you announce the randomization to the world. And so then you can use either intent to treat, or you can use instrumental variable techniques, or you can say, I'm going to just keep these aside and I'm just going to look at the effect of treatment on treated. You have a bunch of different options, and you can essentially be able to present the estimates from all these different options and then make sense of what your data is really trying to tell you. So in our case, we had the same problem because we knew that maybe some villages might protest, maybe some might try to do copycat things, and we have all these problems. So we created matched trios because we have three arms. And basically, we created matched trios of villages and then randomly assigned one to one arm and so on and so forth. Right? So you had these trios. Turns out this becomes adjusting for this in the analysis is very easy. Just as you would do for matched pairs, you introduce one fixed effect for the pair fixed effect. Here we introduce a trio fixed effect, and you're done with that. I'll show you another cool thing from a methods perspective, how it also helps with the balance issue when we come to the results. Okay? So you've seen all of this stuff. So the only thing to remember here is information, although I told you it's just a firm, it was not exactly light touch information. This was to take the Bjorkman Svensson paper very seriously. We collected the data from household surveys, gave information to the villages on their health indicators, also gave households information on rights and responsibilities. So there was a little bit of a political participation type of information that was given to them. And we were sending them IVR, the interactive voice response phone calls, reminding them about upcoming meetings in these villages as well. So overall, it was not exactly cheap, and we never thought that was the point, is to say, a good information intervention should be at least worth doing. So that was the point here. The rest I've already told you about. The analysis, because it comes from a fairly straightforward design, is also straightforward. The three things I will point out to you. One is, of course, you need to cluster your standard errors at the village level in this case, because that's the unit of intervention. We also include district fixed effects, because as you see, we have Fatehpur and Sultanpur. Those are not exactly interchangeable districts. And then the trio fixed effects I told you. The last thing is, because we are looking at multiple arms and multiple treatments across different arms, we will be clearly in a multiple outcomes framework. So you don't want to randomly, by chance, find statistically significant results. So we use step-down, Westphalian step-down estimation methods to come up with family-wise key values. The last thing, and you'll see this in the results, I mentioned to you earlier that we had data from baseline. I will not be using that in our main analysis. And the main reason why is that the baseline data was collected on a much smaller scale for two purposes. One was the government wanted to get a sense of approximate summary statistics for these areas collectively. So the sample size within each area was smaller. The implication of that is that it's a much more noisier measure at baseline for each indicator within the same village. And so the sample size is roughly half. And the second one is, unfortunately, again, because of government contracting processes, the agency that was brought on board did not do a perfectly good job, because L1 contracting, and then they were trying to cut corners. So they were working with a much tighter budget than we had for baseline out of our own research, or for the follow-up out of our own research budgets. So we have more confidence that the follow-up data is better collected and a larger sample size. So what I'm going to do is show you all the estimates using the simple experimental framework and the follow-up data, and then show you the difference analysis in the robustness. And what I can tell you right now is that the point estimates are nearly exactly the same, which is what you'd hope they would be. So the timeline, I told you about this earlier, is we started, the baseline was done in 2015, and between second quarter of 2016 to second quarter of 2017 is when the implementation actually happens. We waited a whole year after that to do the end line. This is not trivial. The reason why we did this is because we were looking at child health outcomes, especially immunization and stuff, which takes 2 years. When you define full immunization, it's at age 2. So we wanted to make sure that children who are born during the period of the intervention, most of them at least the ones who are born here, will have full 2 years to make up, for us to be able to see the effects here. If we start measuring things here, it might not be enough to pick up some of these effects. Right? So we give it some time and then collect the data. What did these things look like? Well, to be honest, we were a little pleasantly surprised that participation actually was really good, at least in the early stages. Right? So for the first few months when our teams were in there making sure things happen, we stood there we waited for about 4 to 5 months, depending on the villages, and then we retreated, let them do their own thing. So during that time, we would see about 70-80 households in the villages show up for these meetings. So this picture you see on your right with this gentleman standing there and pointing fingers, he's not pointing fingers at the hapless women who are sitting there. There are healthcare workers who are sitting next to them, and he's yelling at them, at the healthcare workers, saying, he was complaining in this particular case about his grandchildren not receiving care and stuff. So this was not an unusual setting. People would get into confrontations and people start yelling at each other, saying, you told the committee that everybody got their Dalia last month, but I know that nobody got it, or some people didn't, you're being partial, and exactly what you would want these meetings to do, right? And then in terms of the service delivery, things were quite organized because they knew that this was being run as part of a government program. So the delivery looked, at least on the days when somebody was there to check, it would look well, right? So overall, we knew that number of meetings went up. We know that from documentary evidence that these guys were filing reports of the meetings happening. I should also tell you, these pictures, the government, to their credit, had also introduced a really cool WhatsApp-based monitoring mechanism. So each of the GPCs who was at these villages, in order to show that they have shown up to work, they had to take a picture of the meeting in progress and send it back to the office. That's how they recorded their attendance, right? And their monthly salaries were based on that. So it had the dual purpose of getting a lot of information about the types of meetings that were happening, and as well for them to monitor attendance as well. You might wonder how much all of this cost. So over the period of the year, the information alone cost about $1,750 US, and this was, I think, estimated at about 60 rupees to the dollar. When it was at that time. And then the cost of providing information plus facilitation in those areas was about $1,000 extra on top of that, right? So the facilitation itself cost $1,000. Information alone was $1,750. And to make sure that we have accounted for all costs, we included the cost of different contracts that different agencies wrote with these institutions, including the cost of baseline data collection, some of the cost of the facilitating interventions that we talked about, the World Bank contracts and stuff. We put everything in there, and then we tried to prorate the cost to the village level, because this was done over 12 different districts and lots of villages there. Okay. As I was telling you earlier, the beauty of matched trio or pairwise matched randomization is that you don't need to look at a baseline table, because by construction it's going to be all balanced, right? So that is not inherently surprising at all. In fact, the way you do it is you take your entire set of possible treatment villages, and you take all the characteristics that you think are useful. In this case, we took all observable demographic and village level characteristics. You create a propensity score and then create matched trios based on those propensity scores. So as a result, it's not surprising entirely that there's balance at baseline. So that makes perfect sense. Okay, so at follow-up, what we do is we have 4,800 households that we aim to reach, of which we managed to get to about 4,400 households, and have data from about 5,200 children. We have standard data that I'll be showing you about all the health indicators and satisfaction and all of that stuff. Great, so let's jump right in. So the first set of results is on nutrition. Remember, I showed you right at the very beginning those dots that showed that there was some improvements, but not as much. So that's essentially this. What does this show? These are roughly 3 to 4 percentage point reductions. Clearly not super precisely estimated. The standard errors are around 0.02 or so. But they're all moving in the same direction. Only one of these estimates, which is the one that you see in column 3 and 4 for the second row, is statistically significant. That is the information and facilitation for children being underweight. Now, before we completely, we say, well, there's nothing here because your standard errors are too much, let's just take a second to try and understand what this actually tells us. Is if you just look at the point estimates relative to 50% of children being either stunted or underweight in UP, which is approximately where child health looks like right now, this is a 3 to 4 percentage point reduction. Not precisely estimated, obviously, but it's not a huge reduction. Right? It's nothing like our under 5 mortality dropping by 30% or anything. These are, even if they were there, they're fairly small effects. Okay. You might notice that column 5 and 6, child wasting, there's nothing happening. That's not entirely surprising. For those of you who are unfamiliar with the stunting nutrition literature, stunting basically tells me that your height for age is lower. Underweight tells me that given that you're a certain age, height for age and weight for age are basically what you're looking at. And wasting is basically saying, conditional on being a certain height, how much weight do you have? And this is where a lot of the really bad nutritional outcomes show up on wasting. That's the bad stuff. Fortunately, most of India has moved out of wasting. We don't see that as much. So what you see even in these same places, the percentage of children who would show up as being even marginally wasted are about 25% relative to over 50% for stunting and underweight. Okay, so then we get to this question. All right, so we know that there was some small but not significant effect on nutrition. There were no effects clearly on mortality. Then the question is, do we find something else? We know that these services were some VHNDs and VHSNCs were supposed to promote immunization. So when we look at immunization, what we find is full immunization, which includes the child by 2 years of age, by 23 months, as per NFHS, has fully immunized and received immunization for BCG, measles, 3 doses each for polio and DPT. And the full DPT is now receiving three doses of these, right? What you find here is there's an almost 30% increase in full vaccination rates, right? So going from about 44% of children in the control areas who received full immunization, it goes up by almost 12 to 13 percentage points. This is a very large effect. Okay, so about a 30% increase in the amount of children, in the percentage of children who are receiving full vaccination in these cases. Well, let me just go back and show you one other thing there. It's not entirely surprising that things like BCG do not improve. Right? As we start with, almost 96% of children are receiving BCG when they're born. This is something you get immediately when you're born. So the scope to improve things is very less there. Same thing for measles. Over almost 90% in control area children are already receiving it. So the scope for improvement is relatively low. But as you go down that, you look at full DPT, which is really where things seem to be falling apart, as well as, sadly, even polio. Only 52% of children or mothers with children reported that their kids had received polio. It did go up. 10% is not trivial. This is a 20% increase relative to the 50 that they're starting off with. So that's a fairly large increase even in the full polio. But the big ticket items were right here in the full DPT. And this makes sense. Because for DPT, you're supposed to go for multiple visits over multiple periods in time. And if you have an intervention that's making sure that the VHNDs are held regularly and immunization days are held regularly every month, then it's not the first immunization visit that is going to have the big effect. You're likely to see things that are much more about the repeat visits, which is consistent with this story here. Okay, so this stuff we looked at. Okay. I'll just show you another way of one of the referees, when we got referee comments on the paper, pointed out that we could look at this analysis slightly differently. Okay, and the way you could look at this analysis differently is this is what I showed you, right? The top column here, the top row here is what I showed you. You could run this exact same analysis differently, and I should probably label this slightly different. It should be any intervention, which is now villages that receive either one of those two interventions, and that's the effect of receiving any intervention relative to no intervention at all. And then this is the marginal effect of receiving facilitation. Okay, in some sense, mathematically, this is exactly the same, right? Because 0.0087 plus 0.046 will give you 0.134 here. Same thing here as well. These two numbers should add up to this. Mathematically, it's exactly the same. The interpretation is different. The interpretation here is that information only has some effect. Information plus facilitation has a larger effect. Both are relative to control arms. Here, it's that getting any kind of intervention has the same effect as information, the same effect. In addition to information, when you throw in facilitation, there is some effect, but it's not precisely estimated, and it's positive, but it's not precisely estimated. It's not statistically significant. Mathematically, although these two are the same, I'm going to show you these set of results, not because there are more stars here, but because when we developed this project, the question we were trying to ask was, if you are the government, would you like to do option A, option B, or none of the above? We were not trying to only ask what's the effect of doing anything in a village versus do anything you can, and you give, any information intervention you can, and then you put some additional facilitation on top of it. Right? So there are slightly different ways of explaining the results. So this is what I showed you, and this is the same structure you will be seeing in the next slides as well. But for those of you who are curious and you want to see what the equivalent of this number is, the point of this slide is for you to see that you can very easily derive it by just subtracting 0.088 from the 0.134, and you'll get that number. The difference is across the board, with the exception of one coefficient, they're not going to be statistically significant because the study was not powered to do that. Okay. All right. So then remember, I told you that there's the diarrhea treatment as well. And again, with diarrhea treatment, what you find is, not unlike most of rural India, about 15% of children have diarrhea on any given day. This is a slight improvement. About a decade ago, it used to be about 20. So relative to that, there's not that much of a difference in these areas relative to the control areas. I was frankly a little surprised actually that diarrhea, there was no change at all, but the data is what it is. There was a little bit of improvement in the facilitation areas where better care is now being provided because there's the intervention happening, with children receiving treatment more often within the same day, within the first day of treatment. This is also marginally statistically significant, but this is the only one result here. By the time you do the full family-wise p-value correction and stuff, this doesn't remain statistically significant after that. Then comes this issue of, well, okay, for the children, we looked at the immunization, we looked at their death rates, we looked at diarrhea, the mothers were the next. Although there were no major improvements in terms of at least 4 ANC visits or the number, there's some improvement here, but not that much. This is relative to just over 2 being the average number of ANC visits. Okay, what you do see on the next slide with maternal health care is institutional delivery rates go up significantly for both the information as well as the information plus facilitation treatment arms. These point effects are almost identical across the two. So the effect sizes are about the same. One cannot necessarily say that this is more in the facilitation arms or anything at all. But relative to this is actually not a trivial effect, because you're starting from a situation where most of India today, institutional delivery rates in rural areas are over 80%. So starting from 80%, when you have a 6.87% percentage point improvement, that's a fairly large effect size. Okay. All right, so that was our institutional delivery rates. And then the point I was telling you about the results on satisfaction, again, the effect on interventions is not surprisingly going to be negative, because that's what you would expect to see. I want to keep track of time. We have another 10 minutes to go. So I'm going to race through some of the other smaller results so we can go back and discuss the big picture issues that I promised you we'll come back on. So the satisfaction, not much going on. The last thing here, important point, is we found surprisingly that the births in the last year went down. And this was an incidental finding. This was not part of our pre-analysis plan. The only reason why this came up is because when we looked at all the data that we had on all the births that were recorded in the study, we found that actually there were fewer births that happened in the past 1 year compared to previous years. And we were quite surprised by that might be the case. And this is not a trivial one. If you see, about 35% of households in control areas had a birth in the last year. Relative to that, the births in the both the treatment arms were less by about 5 percentage points. So that's not trivial. We tried to see if it was because of missing data or some kind of bizarre missingness, and it cannot be explained unless we had some crazy amount of infant mortality that happened that is just impossible to explain. So the only explanation then, when we look at the qualitative data, is the intervention areas did also talk about giving out more condoms, and the healthcare workers there said that there were more women who were registered in antenatal care programs and were receiving more condoms and contraceptives. So maybe that's one mechanism. There are some other stories we could possibly think about, but again, this was not central. It's just too big an effect to rule out completely. I promised you the difference in difference estimations as a robustness check. As you'll see, the red is the estimates from randomized intervention and blue is the DD estimates. and exactly for reasons I had mentioned earlier, smaller data set in baseline and messier data because it was collected with on a much lower budget, you would expect to see wider confidence intervals, and that's exactly the pattern you see throughout. If anything, the one estimate which is significantly larger is where the child full immunization is even larger in difference, but it's not that much of an effect. We do look for effect of gender heterogeneity, and the main thing, I'll just bring your attention to the only thing that's sad and important, which is the institutional delivery rates. Red is girls and blue are boys, and what you see here is in the information and intervention facilitation villages. This is the only one that's actually statistically significant. All the effects in terms of improvements in institutional deliveries happened among boys. That negative is actually an error. That should not be zero negative there in the label. But it's all of the effect here. Actually, so no, that is the negative is the difference here. I apologize. All the improvements happened among boys, girls not so much, which is really bizarre, right? Because if our laws on prenatal sex determination are actually being imposed, there is no way you should see differences in institutional delivery rates between boys and girls. Right? There could be two things going on. One is that after being born, these girls are suddenly missing, which would be an even sadder story about the girls being missing after they were born. Or it could be that after the households find out that it's a male child, they are taking more care and are delivering them in the hospitals. Either way, it's a fairly sad commentary on the challenges we face there. Not much going on in caste. There's some improvements that you look like the non-ST. Overall, it looks like the non-SC/ST households get more effects from more sort of improvements in terms of stunting and underweight as compared to the SC/STs. But that's only in the information areas. Information plus facilitation, the gap seems to be narrower, which is good. But again, these differences are not statistically significant with the exception of this one on stunting. So to the extent that anything is going on here, it looks like the stunting effects among the SC/STs is going down, which is good. All right, so let me just tell you about the big picture issues here. We did find some large effects on immunization rates, institutional delivery, and reductions in birth. Some suggestive evidence of improvements, but not statistically significant. Effects of information plus facilitation are larger. They're more often statistically significant than information alone, right? So then the question comes back to scalability. Was this scalable? Well, it was deliberately designed and implemented on a scale level already to start with. It was also very sort of locally contextual. We did not do the implementation design, intervention design. It was done by the government. However, sustainability does not come naturally from there. So when we did this study, the UP government got all these accolades. They were being invited to Delhi for international conferences to talk about their experience and stuff. Despite all of that, and despite the unique relationship that the project had with SIRD, this contract was not renewed. And the sad reality is that when the election campaign time came along, the government made all kinds of promises, and then they ran out of money. So then when they had to decide what needed to be done, this was on the chopping block. So it's one of those bizarre stories where, here you have an intervention that you did your best to try and make it scalable, replicable, all of that, built it with the government. And despite having some positive effects in as rigorous manner as possible, it still was not possible to continue it. So I know it's a little bit of a downer. It's the reality of the kind of governance innovations that we do. We have a few minutes, so let me pause there. I'm sure there are questions that you wanted to ask me and I didn't let you.